braking, and I don't even know what that is. Okay. And okay, let's get going now. So we are recording. We were evenly divided for breaks. What is happening? Oh, we have late breaking vote. Oh, okay. All right. So today we already talked about ileoconduit or ileal or the continent reservoir. We didn't really the big piece that we missed last week, we ran out of time talking about renal trauma. So renal trauma is any time when the kidneys are injured from usually like a blunt force, like an outside factor. So usually think about car wrecks or somebody falling down and hitting their back or their flank area, something like that. So renal trauma is not that the kidney is injured, like the nephrons themselves are having damage, like we're going to talk about this week, but it's actually where there's like blunt force, somebody gets hit with a baseball bat or flank. So what symptoms, like what symptoms are we going to see with somebody with renal trauma? Maybe abdominal discomfort, a lot of times like wherever they were hit, right? Hematuria, yeah. Bruising, yeah, a lot of that bruising around wherever that trauma happened. And then because of that trauma to the kidney, there might be a little bit of kidney impairment. Like we might see their BUN and creatinine go up a little bit because of that renal trauma, but it's because of that outside factor that caused direct injury, not because there's damage to how the kidney is functioning overall. Does that make sense? Okay, it's a little tiny paragraph in your book, but I just want to make sure we know that if we see somebody come in, they got in a car wreck and they got hit on their left flank, and now they're bleeding urine, they've got bruising, their BUN and creatinine might be going up a little bit. We don't say, oh, they've got acute kidney injury, because that's different than having renal trauma. Oh, it gets kind of tricky. I'm not going to go into that. Sorry, sometimes my brain goes on a little rabbit trail and I start talking about it before I decide if I want you guys to come with me on that rabbit trail. Just know to ignore that part. Okay, we're going to talk about acute kidney injury, hydronephrosis, glomerulonephrititis, chronic kidney disease, kidney injury. How do we care for these patients with chronic kidney disease? We're going to talk about vascular access sites with patients with dialysis. Also talking about hemodialysis and peritoneal dialysis. I know from your the syllabus acknowledgement quiz, a lot of you guys are very interested in the renal system. A lot of you have loved ones in your life that have had renal issues or even maybe are on dialysis right now. And it does affect so many people we'll get into more of that, but a lot of our nation does have a lot of kidney issues. So it's important that we understand it. So here's where, as a group, if you're the polycystic kidney disease, oh, I remember who that is. You guys, as we go through, think about how can you remember these things. All right, so polycystic kidney disease. I'm going to let you guys do all the word building and things in your group, so I won't give it all away, right? But it's hereditary. This is something where it is passed on from families. You get all these cysts that build up in your kidneys. So because of those cysts, you get this pain. It's kind of this dull pain in your flank, kind of you feel heavy with these cysts. Hematuria is causing blood. Sometimes it causes hypertension. Why would it cause hypertension? Because you bleed. Because you're bleeding? No.
Because those cysts are messing with the GFR.
They're messing with how the kidney functions, right? And if the kidney can't function and filter out how it needs to, remember everything, yeah, it's building up. The pressure is building up. The kidneys are getting blocked doing what they need to do. So the pressure is building up through the rest of the system in your blood vessels. So you're gonna have some hypertension. You might be more prone to UTI. and it's progressive. There's not a treatment that we have for this right now. So if you have polycystic kidney disease, you're gonna have it for the rest of your life, and we're gonna be kind of doing symptom management with it. So, okay, now we're changing, right? We're on track, moving topics. Diabetic nephropathy. So this is another, when we talk about diabetes later in the term, it will make even more sense. But it's a complication of long-term diabetes, specifically diabetes that's not controlled as well. We have a video in a little bit. I'm going to show you that kind of gives a good visual of this. This is the most common cause of chronic kidney disease that we're going to see in our nation. It talks atherosclerotic changes. That has to do with our blood vessels and how they're able to comply, how they're able to stretch and move. When that gets diminished, the kidneys don't get the blood that they need, and then they don't function as well. Because of this diabetic nephropathy, a lot of times patients will develop chronic kidney disease from this. All right, so quick question for you guys. Which of these actions should the nurse include on a teaching plan to help prevent or slow the progression of diabetic nephropathy? Select all that apply. I checked it last night. Oh, Lord. What is this? It already shows you guys the answers? Oh, well, I don't even know what to do with this. Okay, let's just talk about this then, since I gave you the answers. How is controlling blood glucose going to help stop or slow the progression of this disease? Right? Yeah, right. It's the diabetes that's not controlled that's causing these atherosclerotic changes. So if we can keep the blood sugar in a healthy range, they're not going to have those changes. What about controlling the blood pressure? How is that going to help control this disease?
And it doesn't, blood pressure increase on your arteries, so you get that plaque buildup or whatnot, so.
You could get the scarring that can build up, right? The more pressure, the more pressure it's putting on those kidneys, the more it can cause issue. What about restricting protein in the diet? How is that going to help?
Protein can cause like kidney stone.
Yes, but if we restrict the protein, that's lowering it. So it'd be more carbs. And it's not about kidney stones either. Do you guys know anything about how we digest proteins? Or maybe so proteins are kind of, they're digested, but then they're like cleared in our kidneys. Proteins are one of the hardest things on our kidneys as far as when we talk about nutrients. And so a lot of times patients who have kidney disease, we tell them to actually restrict the amount of protein that you're eating because it is more difficult on your kidneys to kind of process and filter those out. The caveat to that is if they're on dialysis, then usually they won't restrict the proteins because the dialysis sessions will help to clear that. No question?
What you thinking, because I'm on a diabetic side, some people eat.
We want more protein and less carbs. It's very tricky. I'll tell you guys as we go through, I have a neighbor, Miss Betty, who lives across the street. Her husband died in the middle of COVID. It was so sad. He was running on the treadmill in their basement. She went to get him for dinner and she found him on the floor. They think he had a massive heart attack and died. And so I didn't really know Miss Betty much before that, but afterwards we became really close. She started having a lot of medical issues. In fact, last week I didn't really talk about it so much, but I mentioned those staghorn calculi. You guys remember what those, why do we call them staghorn calculi? Yeah, it's those kidney stones that kind of have those things that it almost looks like a stag that like build out into the kidney. She had a massive one of those, one of the biggest ones the doctor had ever seen. She had to have a nephrectomy because of that, which nephrectomy, right? Neph, kidney, ectomy is removal. Yeah. She already had a family history of chronic kidney disease. So she was very worried that when she had her kidney removed of what was going to happen to this remaining kidney. And then she started having some other health issues. She had acute kidney injury, we'll talk about in a little bit. She doesn't have chronic renal, she doesn't have renal failure to the extent that she needs dialysis right now, but we stage our kidney failure. Our nephrons, guys, our nephrons are amazing. Anybody remember from the book how many nephrons that you have in your each kidney? About 1 million. 1 million. And when we talk about chronic kidney disease in a little bit, we're going to talk about how really we don't start showing signs and symptoms until about 75% of those nephrons aren't working anymore. Isn't that amazing? That's like, I think Amazon employs about 1.5 million employees. And so we've got 2 million nephrons, right? That would be like if 75% of Amazon employees just decided not to show up, not to work, but they were able to still package, box, deliver all those packages that you see all the time. Like our kidneys are incredible. They are hardworking. I was talking about Miss Betty. Why did I talk about it? Oh, because once she started having this chronic kidney disease, right? It's not to the point she needs dialysis. She also has type 2 diabetes. Now, when we talk about type 2, we'll talk about diabetes later, but she was really angry because she said, I got type 2 diabetes and they told me if I exercised and I lost weight, it would go away, and it didn't. It doesn't always. It usually can really help control it sometimes. And the thing is, it doesn't ever go away, right? It's controlled, it's managed with your lifestyle changes, with eating right, exercising. She still needed medication, so she was very upset about that. But with her diabetes and with her kidney disease, that was something we for months were working on her diet, because she knew, because of her kidney issues, with only having one kidney that was already compromised, she knew she wasn't supposed to eat a lot of protein. But as a diabetic, she also knew, I don't want to eat a lot of carbs. And so we really had to work hard to figure out, how do we get enough food, the right kind of food that's healthy, because she also had high blood pressure, so we're avoiding other things. And she was on Coumadin as well. So you also have to kind of watch what you eat with Coumadin. Just a sec, we're not even talking about that. But what, do you guys remember anything about, have you talked about Coumadin yet?
Vitamin K.
Vitamin K, right? Vitamin K counteracts Coumadin. This side of the room. What kind of foods have a lot of vitamin K in them? Yeah, like our fresh green vegetables usually, right? And so, like, we've already taken out protein, we've taken out carbs. Now we want to limit the amount of fresh green vegetables. We were like, what do we feed you? Anyway, just to go, it's just so complicated for a lot of these patients. And you can see how, even as a nurse, I was like, just I don't know how, like, how do I help you? What do I do? So you can see how patients get so frustrated and have a trouble complying and say, like, they might be like, there's no way, I can't figure this out. And so why even try? So there's a lot of issues with compliance. It is really tough. Okay, that was a really long rabbit trail, but I think a good one, right? Like, we learned stuff about protein. You guys got to meet Miss Betty. Okay, let me get back on here. All right, so diabetic nephropathy. We're continuing on with this. So how do we control it? Our early interventions are trying to keep that blood pressure and glucose controlled and restrict the protein. Later, it probably is going to require dialysis as it progresses. Eventually, they might need a kidney transplant. We'll talk more about transplants later. Our bodies isn't it baffling at how amazing our bodies work? And that even we can take a part from somebody else and put it in another person. It's amazing. Nursing care, we really want to reinforce this teaching about how to prevent the progression. We really want to sustain as much function as possible. All right, so now, who's our nephrotic syndrome group? Somebody? You guys? Okay. So this is where you have an issue with the nephrons. Excuse me. So we want to treat the cause of it. We'll go back to the cause of it in just a minute. But with nephrotic syndrome, the body just starts, normally we'll keep some protein, right? Your body just starts to excrete it. It's having all the protein lost. Because of the membrane, it's really permeable. So because of that, your albumin, your serum protein, it drops. Because of that, your body's going to hang on to more fluid. you're gonna get more swollen. So you might see people have edema. Ascites.
Accumulation of fluid in your abdomen.
No, thank you, Siri. Yeah, somebody said the fluid buildup in the abdominal cavity. Sometimes you'll see people who look like they're 10 months pregnant, but it's a guy. And you're like, oh, that's ascites. That's a big fluid buildup. Anasarca, general, overwhelming whole body edema. Your liver starts producing these lipoproteins. Those start making your urine foamy. Anybody ever seen foamy urine? Yeah. Yeah, I mean, not just like it gets kind of bubbly because it goes in the toilet a little bit, but it actually gets foamy. It's really weird. You start losing some of your clotting factors. Treatment, we want to treat the symptom. What caused the damage? And why is that membrane so permeable? So, nursing care, we really want to look at that edema and the protein in the urine. Those are the biggest things we're going to see. So we're going to be doing daily weights, I&O, abdominal girth. Why would we do the abdominal girth daily on patients?
If it's growing, the ascites is growing.
Yeah. See if there's any ascites, if it's developing, increasing. We want to do infection prevention. We really want to do malnutrition prevention. We want to make sure they're getting good nutrition, a lot of probably extra protein to try to build up what they're losing. And because of those clotting factors that are inhibited, we are also probably are not inhibited, but they're changed. They're more likely to get a blood clot. And so we're probably going to have them on a blood thinner, or maybe we're going to do some other things to help prevent blood clots. What other things are nursing like interventions we can do to prevent blood clots? SCDs, walking. Did somebody say dehydration? Because if you did, that's really good. All right. Moving on. Nephrosis or nephrosclerosis group? Nephrosclerosis. Okay. All right. So that's where you have high blood pressure. That pressure damages the blood vessels, right? It causes like scarring. We'll talk more about atherosclerosis when we talk about cardiac stuff later in the term. But that high blood pressure causes scarring in the blood vessels. That scarring of the blood vessels in the kidneys causes damage to the kidneys. So we give them hypertensives. This also includes a nursing diagnosis, maybe ineffective health maintenance behaviors. Maybe they're not doing the things they needed to keep the blood pressure lower. Okay, moving, like I said, these are short, you guys. Who's our glomerulonephritis group? Hey, back there. All right, so glomerulonephritis, that's where the glomerulus, that part of the kidney gets really inflamed. So the glomerulus gets more porous, which allows things to go through more. So protein, white blood cells, red blood cells, those are all leaking out into the urine as well. Causes, one of the big things with this one, post-streptococcal infections. Usually with these patients, we'll see they had like strep throat or some sort of streptococcal, which is a bacteria, some sort of that type of strep bacteria infection. For some reason, that triggers this glomerulonephritis. We won't talk about that more. It could lead to chronic glomerulonephritis. We're not going to talk about that so much, more focusing on the acute glomerulonephritis. Was there a question? So much. Okay. We'll get to that in a minute. Okay, so with glomerulonephritis, they have oliguria. What is oliguria?
Little urine.
They can have a little urine, right? Their blood pressure can go high, right? So retaining all that fluid. Their electrolytes kind of get out of balance because your kidneys aren't working like they should to filter out or keep the electrolytes that they need. You might have edema, and then you might even have some flank pain, which kind of makes sense, right? Kidneys, usually referred pain is back to our flank. Diagnostic tests, elevated BUN and creatinine, just like which other disease process had foamy urine?
Nephrotic syndrome.
Nephrotic syndrome, right? Because it became more porous of the nephrotic syndrome, you let more protein out. This is the same. And so you also are gonna see urine that's dark and foamy, because with this one, it's concentrated, right? And you're not urinating as much, but it's still foamy from all those proteins that you lose. We might do a urinalysis, ultrasound, x-ray, they might even biopsy. Again, most of these cases resolve in about a week. That's the acute glomerulonephritis that we're talking about. Nursing care, vital signs, symptoms, rest. We might even do some fluid, sodium or protein restrictions with these guys, right? Because they're excreting, or pardon me, they're excreting some things too much, they're building up some things too much. So we're trying to kind of match that. Okay. I think it's after this video, we're gonna stop and do our group work. So this video is really nice. This talks about acute kidney injury, but it kind of it describes some of these processes that we're talking about, and it describes kind of the physiology of the kidneys. So let's get into this.
It's not functioning. Use function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF. But AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types. Pre-renal AKI, the cause of kidney injury is coming before the kidneys. Post-renal AKI, meaning after the kidneys. Or intrarenal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood. So they might remove waste or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery, into tiny clumps of arterioles called glomeruli, where it's initially filtered, with the filtrate, the stuff that gets filtered out, moving into the renal tubule. Sometimes fluid or electrolytes can move back from the filtrate into the blood, called reabsorption. And sometimes more fluid or electrolytes can move from the blood to the filtrate, called secretion. Along with fluid and electrolytes, though, waste-containing compounds can also be filtered, like urea and creatinine. Although some urea is actually reabsorbed back into the blood, whereas only a little bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20 to 1. Meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good diagnostic for looking at kidney function. Ultimately, that filtrate is turned into urine and is excreted from the kidneys through the ureter into the bladder and peed away. Meanwhile, the filtered blood drains into the renal vein. Typically, intrarenal AKI is due to damage to the tubules, the glomerulus or the interstitium, the space between the tubules. Starting with the tubules and the most common cause of intrarenal AKI, which is acute tubular necrosis, which is where the epithelial cells that line the tubules necrose, or die. One way this can happen is via ischemia, or a lack of blood supply to the cells. A lot of times acute tubular necrosis due to ischemia is caused by some pre-renal acute kidney injury, since pre-renal AKI results in less blood sent to the kidneys, and those epithelial cells need oxygen from blood just like any other cells. In fact, all that secretion and reabsorption in the tubules takes a lot of energy, and so these cells are particularly sensitive to a loss of blood supply, especially the cells in the proximal tubule, the medullary segment of the thick ascending limb. The other way epithelial cells can necrose is via nephrotoxins, which are substances that tend to damage the epithelial tubular cells. A few of the common ones being aminoglycosides, which are a group of antibiotics, heavy metals like lead, myoglobin released from damaged muscles, ethylene glycol, essentially antifreeze, which is naturally sweet tasting, and therefore a risk for poisoning children, radiocontrast dye, and uric acid. That last one, uric acid, is a waste product that can build up when cells die during cancer treatment, called tumor lysis syndrome. And it's the reason why staying well hydrated to improve flow through the tubules as well as using medications like allopurinol and urate oxidase to lower uric acid levels can be so important while on certain chemotherapy. Whatever the cause of cell death is, when those cells die, they slough off into the tubule, and basically build up and plug the tubule, which, just like in post-renal AKI, generates higher pressures in the tubules, which means fluids essentially trying to flow from high-pressure arterioles to high-pressure tubules, which doesn't work very well, and the fluid filtered across is lowered, which lowers the glomerular filtration rate, or GFR, which is how much blood kidneys filter in milliliters through their glomeruli per minute. With less blood being filtered, less urine is produced, called oliguria, abnormally low urine production, and less urea and creatinine get filtered out, so more stays in the blood, called azotemia, high levels of nitrogen-containing compounds in the blood. Along with that, dead cells aren't very good at reabsorbing or secreting molecules anymore, right? So other things start to build up in the blood as well, like potassium, called hyperkalemia, as well as acids, called metabolic acidosis. Also, these dead clumped up cells in the tubule form a brown granular cast, which will eventually get excreted in the urine. It's called a cast because it stays in essentially the same cylindrical shape as the tubule. If the underlying cause of acute tubular necrosis is addressed, people can recover because tubular cells can typically regenerate over the course of a few weeks. Alright, another type of intrarenal AKI is glomerulonephritis, or GN, which means inflammation of the glomerulus. GN is often caused by antigen-antibody complexes depositing in the glomerular tissue. This deposition activates the complement system, which is a cascade of enzymes that attracts other immune cells, like macrophages and neutrophils, to the site, which then release lysosomal enzymes, causing inflammation and damaging the podocytes, which are the cells that line the glomerulus. These normally have small gaps between them and have a negative electrical charge, both of which prevents large molecules from filtering through. When damaged, though, membrane permeability increases, and large molecules are allowed to be filtered into the urine, like proteins called proteinuria, and even red blood cells called hematuria. Also, this fluid leakage reduces the pressure difference that drives filtration of small molecules and electrolytes like sodium, and so the GFR actually goes down because of this leakage. Lower GFR means less blood gets filtered and so less urine is produced, causing oliguria. And that also means more fluid circulating in the blood, which leads to edema or fluid buildup in the tissues, as well as hypertension from excess fluid volume. Finally, if those nitrogen-containing compounds aren't being filtered out, more stays in the blood, which causes azotemia. Alright, finally we have damage to the kidney interstitium as a cause of intrarenal AKI. One key example being acute interstitial nephritis, which is inflammation of the interstitium over the course of days to weeks. This inflammation is caused by infiltration of immune cells, like neutrophils and eosinophils, which then cause inflammation. This is thought to be a type 1 or type 4 hypersensitivity reaction, and is typically a response to medications like NSAIDs, penicillin, and diuretics. Early symptoms include oliguria and eosinophiluria, which is eosinophils in the urine, but also general symptoms like a fever and a rash. These symptoms usually subside if the medication is stopped. But if the medication isn't stopped, then the immune cells continue to damage the connective tissue in the interstitium, and those kidney cells can start to die off, called renal papillary necrosis, where the renal papillae are destroyed. This can again cause hematuria, blood in the urine, as well as flank pain. Other potential causes of renal papillary necrosis are chronic use of analgesics, like aspirin, as well as diabetes mellitus, sickle cell disease, and pyelonephritis. In general, with intrarenal AKI, kidneys lose the ability to filter the blood properly, and so the cells are often damaged such that reabsorption and secretion are impaired. If the urea isn't reabsorbed, less urea stays in the blood relative to creatinine. The BUN to creatinine ratio falls to less than 50:1. Also, those cells can't reabsorb sodium, meaning that urine sodium goes above 40 milliequivalents per liter, and the FBNA, which is the fraction of sodium excreted in the urine to total sodium filtered, expressed as a percentage, goes above 2%. And finally, since water is not being reabsorbed as much, urine osmolality falls below 350 milliosmoles per kilogram. So as a quick recap, Intrarenal AKI is kidney injury caused by something within the kidneys themselves, which could be the tubules, as in acute tubular necrosis, the glomerulus, as in glomerulonephritis, or the interstitium, as in acute interstitial nephritis. Now you know all about intrarenal AKI. Check out these other two videos on pre-renal AKI and post-renal AKI.
I am pretty sure. Yep. Okay. So let's do our group work. Let's take about 5 minutes, get together, come up with some study tips, word associations, anything you think that might help you to remember your group's disease process with what it is, maybe signs and symptoms, be creative with it. And then after 5 minutes, we're going to share with each other so you guys can help each other as you study. Zoom. All right, and which group wants to share first? I saw in the back a hand and then up here. So let's start in the back and make sure to tell us what disease process you have.
But it's glomerulonephritis.
Glomerulonephritis, yeah.
And easy way to remember it is just as we've been doing, breaking down the word from the prefix and suffix, understanding the structure and that information. So we came up with a mnemonic that just highlights the key features of it, which is PARMS. So big pharmacy, but like PHARMS. So the P stands for the protein excess you'll see that comes out in the urine. And then the hematuria, H is for hematuria, A is for the high levels of anemia, R is for retention and edema, and then the M is for malaise or fatigue, as well as S being for the triggering of the post-streptococcal infection.
Yeah.
So I feel like that would be good for remembering like this.
I like that. You guys all heard PHARMS, PHARMS.
Miss A and R. A is for the azotemia level. And then the R is for retention, which could be the, that makes you feel that. What were the in the S? Oh, malaise. The M is malaise for fatigue, and the S is for streptococcal, because that's the bacteria. You'll see it trigger from that in the two positions.
Yeah, nice job, you guys. There you go. Now you know how to remember signs and symptoms and things of pyelonephritis. Or glomerulonephritis. Goodness gracious. Keep me straight, you guys. Okay. Group in the front. Who wants to share?
I will share for our group. So our group had polycystic kidney disease. I think one of the easiest ways to remember this is poly, meaning many, and then cystic for the cyst. So it's fluid-filled cysts that can build up in the body, but it's mostly on the kidneys. And 90% of polycystic kidney disease cases are actually from an autosomal dominant gene, which is carried by one of the parents. And so that means each child would have a 50% chance of inheriting polycystic kidney disease. And then and if both parents have the gene, the child has only a 25% chance, and that would be a recessive gene. And then so this can cause fluid buildup in the body, which can also lead to hypertension, blood in the urine, flank pain, pretty similar symptoms to a lot of the other kidney diseases. And then what else do we have? Oh, it's just another thing is, and if you are worried about passing it down, you can always do genetic testing. To see if you're a carrier of the gene. This does affect 1 in every 400 to 1 in every 1,000 people.
All right, thank you, polycystic kidney disease group. Anybody else want to share? No? How about this group over here? You guys look ready.
Diabetic nephropathy. And we said the most easiest way to know what it is and what causes it is it's kind of in the name diabetic. And the cause is having a long-term complication of diabetes. And then the symptoms as well as how to treat it is very similar to just having diabetes. You want to maintain it, treat your blood pressure and glucose. So just really think of how you would treat diabetes, how you would treat this symptom or this disease process. And then also think diabetes causes your veins to constrict, which decreases the blood to the kidneys. And it's associated, it's the most common cause of chronic kidney disease. So if diabetic nephropathy becomes, gets past the early stage, think of how you would treat chronic kidney disease, which would be dialysis and then, or kidney transplant. So, yeah, kind of relating it to other.
It's like it's basically like a cause and effect from diabetes. That's like, how would you look at it? It's kind of like a snowball. So if you don't really take care of yourself, you will end up, developing.
Getting worse, yeah.
that's pretty much it.
Nice, thank you.
I was just gonna say we have diabetic nephropathy as well.
Yep, some of the groups are twice,
Yeah.
but that's great because actually, why don't you guys build on what they said? Like, I'm sure you guys didn't have the exact same things.
Pretty much. With the hemo or dialysis, there's hemodialysis or peritoneal dialysis. And dialysis is a treatment used because it's taking the place of what your kidneys are supposed to do for your body and that they're not able to do. So that, that dialysis flushes out your system, the waste products that.
Yeah.
And earlier you had mentioned about the protein, possibly, you know, if we need to restrict protein, but if they're on dialysis, then that. may
Then you
not
don't
be
have to,
such a
yeah.
issue.
All right, thank you guys. Thank you both groups. That's funny that you were all both in a row there. Unintentional. Okay, anybody else want to go before I call? Okay, yeah, let's go.
Okay, so ours is somewhat of a song combined with a poem that doesn't rhyme. But here we go.
So we had nephrotic syndrome.
So if you have excess foamy protein or urine in your protein, an edema, ascites, and a sarca, then you will be treated with anticoagulants to prevent thrombosis. Don't forget the daily weights, I and O, and abdominal girth, and watch out for infection and malnutrition because you have nephrotic syndrome.
That's amazing. I don't know if everybody could write that down, but I was thinking, I just made an announcement before class for a case study we're gonna do later. Maybe if you guys have longer things or even the farm thing, if you guys, somebody in your group just wants to comment what you had, that might be a little bit easier way of sharing some of the pieces. That was really creative.
Good job.
Did you guys all come up with that? Did anybody actually sing it? Oh, nice. Okay, yeah, when you can, let's put that in the chat too, so people can kind of see it too. Okay, we have 3 groups left. Who wants to share? Oh, yeah, way to be brave.
You have the renal trauma, which we also came up with with so like core right here. So it's
We have the BP, remember BP for blood and penetrating trauma for renal trauma, and then we have mnemonic for core, which is, remember contusion for blunt trauma and kidney, the O for organ laceration or tear in the kidney, and then renal artery vein injury, and then P for extravasation or the leakage of urine from the kidney.
Okay.
And we also came up with the steps in taking care for renal trauma, which you have to remember, trauma kit.
Oh.
So for management, this tenderness in the flank, rapid pause, those are the ones that you will look out for this trauma kit. Tenderness in the flank, rapid pulse, abdominal bruising or swelling, urinary blood or hematuria, monitor with CT or ultrasound, assess the severity, keep the hemodynamics stable, immediate surgical intervention for severe cases, and detect complications.
Oh, that's amazing.
Okay.
Trauma kid. I like it. Okay, I have another idea before I start. These are such great resources. Has anybody looked on the course at the peer-to-peer open forum, the discussion board that's in class? So in the welcome module or on the weekly resource page, or not week resource, excuse me, the week overview page, there's a link at every overview page to either a instructor help discussion board or the peer-to-peer discussion board. I think these might actually be better, easier to find on that peer-to-peer open forum. In fact, that's a great way for you guys if you have study tools and things to share easily with your class. So let's, instead of doing it on the announcement, let's do it on that peer-to-peer discussion board, because I think that'll be easier for you to find it than having to scroll through announcements. Okay, in the back, who wants to go first? All right, yeah. Thank you. We have a group that already had that already. Some of them I gave out twice. Yeah. Okay, and then I think this, our last group in the back, is that right? Last one? Nobody else? Okay.
We have glomerulonephritis.
They're hard, guys. This is a safe place to practice out saying these words. They are hard.
Inflammation of the glomeruli in the kidneys. It may be caused by infections, autoimmune diseases, and some certain medications. And with that, you can see, you can get the bacteria, blood in the urine, or proteinuria, and edema.
Yes.
I think, the only thing I can add on to that is the diagnostics, in the beta keratin, I think they shared that. And, numerics, ultrasound, x-rays, biopsy, that's how they find it out. And then the therapeutic interventions are usually, like you say, doesn't last longer than 1 week. And, as a nurse, you need to monitor the vitals, support your patients on the symptoms, and then encourage them to rest, and then check on the fluid, sodium, protein restriction, and then repeat.
Yes. Yeah, nice job. Okay. Hey, give each other a round of applause. I encourage you guys to find ways to get this information to stick in your brain. If it's making a song, if it's making acronyms, if it's going over it, like whatever it is that works for you. This is hard. This, like these, we already talked about so many disease processes this morning. There's a lot, right? So we got to find ways of how to memorize them. And you guys, I love that now as a class, you've all come up with different ways of remembering these things. And now we get to share that with each other, right? We're helping each other. So let's go ahead and take a break. Let's go through to quarter or half past, so till 12:30, and then we'll come back. We're still going to be in our groups because we're going to keep doing our group work. You didn't, okay. Well, if you watch the video, you're going to miss all of that fabulousness. Okay. Hmm. Good thing I have backup. Sorry, I'm too cheap to pay for like. All right, let's get back over to the Menti. I don't know why it was being so particular. Okay, so chronic kidney disease, it's the 9th cause of death in the US, which is pretty surprising, right? Like we think about how you can live for a long time on dialysis and all these other things we can do for it, but it's still, when you look at our causes of death in the US, it's the 9th cause because it does contribute to so many people's, the reason why they end up passing away. It's that gradual decrease. So if you're looking at somebody, if it's acute kidney injury versus chronic renal failure is also always going to be slow, gradual, where the acute kidney injury is going to be sudden, where they go from kidney function fine to all of a sudden kidney is not working well. It can come from a bunch of different reasons. This really talked about it. Remember we talked earlier about renal insufficiency? 75% of the nephrons lost. Isn't that crazy? 75. It's just so amazing to me. Then they talk about different stages. We're not going to go into the stages. That's when they're, you guys know what a doctor who specializes in the kidney is called? Nephrologist. So a lot of times somebody has kidney disease, they're going to consult nephrology and have a doctor provider that specializes in the kidneys to come see that person. They're the ones that are going to stage them. But no end stage, very last stage of kidney function, there's only 10% of those nephrons working. That's incredible. So uremia, we talked a little bit about the urea in the blood. That uremic frost, I think the video talked about that, didn't it? It's really crazy if you ever see that on somebody. I've seen it a couple of times when I was a CNA. I worked on a floor that had people with chronic kidney disease. And the few times that I saw it, I was like, whoa, that's weird. But our body does crazy things. It's really interesting. And chronic kidney disease, it doesn't just affect the kidneys. It really does affect the whole body. So signs and symptoms, a lot of times, if you think about the kidney's not working, it's not excreting fluid, it's not excreting all the waste products like normally. So all the fluid stays in your system. It's going to back up. So you're going to have edema, right? Swelling in your tissues. Why would we have shortness of breath?
Too much fluid.
Right, in the lungs, it's going to back up in the lungs, right? You might have some, when you think about just fluid backing up, sometimes these patients get so fluid overloaded. Backing up in your lungs, short of breath. If you get backed up in your blood pressure and your blood vessels, how you gave it away, right? Increased blood pressure. Sometimes it can even be fluid, you get overloaded and it backs up in your internal organs. And sometimes it can slow your digestion because your digestive system is a little bit fluid as well. You can have a lot of electrolyte imbalances. So when we look at renal, the biggest electrolyte we look at generally is potassium because your body isn't excreting potassium like it normally would. Potassium's a really tricky electrolyte. It's so good. It has so many good functions in our system, in our body. But if we get too much or too little of it, there's one system in general that really gets irritable. You guys know what system that is? Yeah, the cardiovascular system, the heart. The heart's really sensitive to potassium. Doesn't get enough, it gets irritable. It gets too much, it gets really irritable. Sometimes with these patients who have renal failure, we'll see their potassium levels be really high. And we got to treat that. We'll talk about that more in a minute. Do acid-base imbalances. You guys learned about different acid-base imbalances last term in MedSurg 1. So hopefully you can understand a little bit more about how when the kidneys are impaired, it prevents them from releasing hydrogen ions. It helps because it keeps them from kind of either excreting some of the electrolytes that they normally would. And anemia, because with anemia, you guys, I think the video touched on it a little bit. How do kidneys affect red blood cell production? Yes, erythropoietin. They produce the hormone erythropoietin. Without that hormone, our bone marrow isn't stimulated to produce red blood cells. So a lot of times our chronic kidney failure patients, we give them a medication like epogen, or there's some other names for it, but it sounds similar to erythropoietin. And it helps to, it's like an artificial hormone so that those patients will be stimulated to produce more red blood cells. Okay, I said group work for electrolyte imbalances. Okay, so look at you should have a sheet that has kind of like this with the renal, like different electrolytes on it. So in your textbook, pages 685 to 686, they go over how these different electrolytes or lab values are changed, excuse me, by renal failure. As a group, I want you guys to go through and fill these out. Let's take about 10 minutes to fill these out. And then we're gonna share, I'll call on different groups to kind of share what they know. 685 to 686. Zoom recording, okay. We're back at it. Okay, before we get to the kidneys and potassium a little bit, I kind of like this sheet. This picture, this is from your book. So if you like this, go look at it more in your book when you're studying. This talks about all the different systems that are affected by renal disease. And really it's every system. But like we talked about with the GI system, there can be some nausea and vomiting, anorexia, people not wanting to eat as much. Some of that is from the swelling they can have with their intestines. Other of it could be from the toxins that are built up in their system that make you nauseous and you don't feel good. The musculoskeletal system, you're more prone to fractures, right? What's the hormone that our kidneys produce for red blood cells? Yeah, that wasn't actually related to the bones, right? Related to calcium, because what do the kidneys activate that's related to calcium? Vitamin D. Okay, well, I went on a weird path with that. Itching. A lot of times are my patients that are dialysis or have chronic kidney disease, they're very itchy. It's those waste products that aren't being excreted from the kidneys. Their body's just trying to get rid of them. So they actually are excreted some through the skin, and that's why they're itchy. From some reason, and I don't ever know how, I never see this in books, but in my experience, every dialysis patient I've ever taken care of is always very cold. Like if you give them a warm blanket, you are their best friend. A lot of you guys are nodding. I don't know why this is. I have never seen the reason.
Anemia.
Maybe it's anemia. Maybe it's, their body is filtered out of their system and it comes back and there's warming. Yeah, the dry skin. It could be a lot of these different reasons, but just know your dialysis patients are going to be cold. Anyway, so a lot of issues when you're studying, this is a good one to look at to see how the renal system is affected, or affects the rest of our body. So therapeutic interventions, we want to give them a lot of calories, but hopefully not a lot of protein, right? Unless they're on dialysis. Again, this gets complicated. Like we talked about having our patients who are diabetic, who maybe we don't want to give them a lot of carbohydrates or things that are going to affect their blood sugars as much. We want to do low sodium, low potassium, low phosphorus. And so that, right, again, this gets complicated. We think about why aren't our patients compliant? Why don't they do what we tell them to? It's hard, it's hard to learn how to read labels, to eliminate things when you might not be able to eat your favorite food how you want to. A lot of times we do fluid restrictions for these patients because their body can't flush out the fluid like it needs to. Even if they're on dialysis, we still want to limit their fluid intake because they're still going to get really built up in between dialysis sessions. I would almost always see when I worked at the renal failure floor after holidays, we see big uptick in patients being hospitalized because they would go and they'd be with their family and they want to eat all the food they normally did. They maybe would skip a dialysis session if they were doing other things, and they come in just fluid overloaded. And they would have to get some emergency dialysis, maybe sometimes a couple times a day, to get all that fluid off them before they could go back home. So, moving on. Okay. I don't think I'm going to have time to go over the medication. So the medication sheet, keep it. I'm gonna publish the answer sheet later. But just know we're not gonna do that today. The question that you had, Casey, was about potassium. So the potassium reducers. So potassium and calcium, they also kind of have a correlation with each other. So if we give somebody calcium gluconate, increase that calcium level, it actually drives potassium back into the cells and lowers that serum potassium level. When I say serum level, that means in the blood. So anytime they say like a serum ammonia level or serum potassium, that means blood level, serum. So insulin and glucose IV, super interesting. So insulin, one of its actions is that it kind of opens up these channels into your cell. It allows glucose to go to the cell, but it also allows potassium to go into the cells, right? So that will lower the serum potassium. But like I said, it also allows insulin to go, or glucose to go into the cells. What's that going to do to their blood glucose levels? It's going to drop it because all of that glucose is going to go from the blood into the cells. So it's going to drop the blood glucose level. So that's why if we ever do this, we give the insulin IV, we follow it up with some glucose IV so that it replaces the glucose that's being taken up into the cells. Kayexalate, that's a nasty one because it pulls out the potassium from your bowel, and it does it by giving you diarrhea. It specifically targets the potassium and it pulls it out and you have diarrhea and it's uncomfortable and people don't really like it, but it can work. Or this Deltessa medication, I'm not too familiar with this. I haven't seen it a lot, but it's an option. Usually what I see if the potassium level is critically high, in my practice, I've seen a lot more of the IV potassium or IV glucose with IV insulin. As an LPN, I don't think you guys would probably be giving that. That would be the RN who would be giving it, but you would be monitoring. What do we want to monitor for, let's say in the next hour or two after we give this? The blood glucose level, right? Anytime we think about we're giving IV insulin, we want to monitor that glucose level. Even though we gave IV glucose, we're still going to be checking. Welcome, Chooch.
During a break, but
Oh, I don't believe in breaks. I'm just kidding.
I thought we would have more of these for this, but there was only 4 hours straight.
Yes. You're gonna become nurses.
There was not, there was only the little one.
Oh, yeah, take whatever you need. So these patients might have, like, what are we gonna do? If they're on dialysis, we're gonna monitor fluid, potassium levels, any neurological signs or symptoms, because it can affect your neurosystem too, and uremia as well. Okay, let's do this and let's go on another break, because I feel like we need like a little something. All right, so we're reviewing the following laboratory results of a patient who was admitted to your unit with renal disease. Calcium levels 9.5, potassium level 7.0, magnesium level 2.0, BUN 18. What do you do? So go ahead and turn to your neighbor, to your group, talk about what would you do if this patient was admitted to your department?
calcium's okay. That's joint.
So we also have 9 to 11. All right, hopefully you've had a little bit of an idea.
We have to ask you them about everything.
What about you guys? You probably heard a little bit. So I heard from somebody over here that the potassium is very concerning. Right? Right, it's very high. That's a dangerous, or what we would call critical level. You guys are gonna learn if you get a critical laboratory result, which could be a potassium that's very high, or let's say you got blood cultures from someone and that is showing bacteria in the blood. That's another thing that's called a critical laboratory level. One thing that's important that you guys know is that you must write a note when you get critical levels. Your facility will probably have some sort of policy with that, but all you do is you write something like critical lab result, critical lab value of 7.0 potassium at whatever time. Provider so-and-so paid to notify at this time. And then once the provider says, "Hey, let's do whatever we're gonna do to fix it," then you would follow up with another note to say, provider acknowledged results, orders received. And you don't even have to say what orders there are. You just have to acknowledge that that was conveyed to the provider and that you got orders for it. So.
We don't panic, like, what do we do? And all we have to do is document.
Well, you're not just documenting, right? We're monitoring the patient, right? Because what system are we really monitoring with this level?
Cardiac.
Right? We're probably, even though I don't have an order for it, I'd probably throw them on telemetry if it was available. Just because I know, and some of this is like seasoned nurse that you just know, I would, if I'm calling the doc, I would say, hey, I got a potassium level of 7. Just so you follow S-bar, right?
Yeah.
You follow the S-bar. I'm gonna tell them, I went ahead and put them on telemetries to make sure and I would tell them, hey, they're in sinus rhythm, or, I would tell them what that is, to see if they're having any results. And then I would give recommendations or ask them, what do you want me to do? But, we're still doing things, but you just wanna make sure you document.
Oh, I was gonna ask you, when you saying write a note, are you saying write a note in the actual patient's chart?
Yep, when I say right, so progress note, call that nursing progress note. And so there's a lot of, like, in lab for fundamentals, you guys practice doing like the assessments, is that right? In EHR tutor, I think. And I think we're not doing as good as prepping you with progress notes. And so Chuchi and I have been working intentionally about how to give you guys more practice with progress notes. And so just kind of introducing it with things like this, but then in clinicals, giving you assignments to actually practice writing. Because all the clinical places, they don't necessarily let you write in the patient's chart. And so we want to give you areas to practice here as well. You're welcome. Okay, what did F.A. Davis say? It said, yes, call them because that's too high. And that's it. Okay, so let's take another break. We're done at 3?
Yeah.
Oh, we have so much fun stuff to still do. Can we get by with like coming at 5 after? Is that enough time for you guys? Yeah, okay, let's come back at 5 after, and then we'll be able to finish with all of our fun stuff for today. Okay, so hemodialysis. So when we're talking about chronic kidney disease, we say, a lot of times we'll say dialysis. Most of the time, we're talking about hemodialysis, but it's good to differentiate and know what that means. Hemo or heme usually means blood. Dialysis is the process of like filtering out all the toxins, waste products, extra fluids from the blood. So you're gonna have to have some sort of way of accessing the blood system or the cardiovascular system. If it's, when somebody first starts on hemodialysis, they will always put in a temporary type of access. That's a type of central catheter. This doesn't really show specifically what type of catheter, but it kind of gives you an idea. Typically, it's in, sometimes they'll do an internal jugular, where the access will be in the neck. That's very temporary. Usually want those in for 7 days or less. And then sometimes after that, they might even put a tunnel catheter in. This is a type of tunnel catheter. It doesn't really look what the dialysis line would look like, but it is where you can kind of see it goes underneath the skin. After class, if you want to come look, you kind of feel how it's tunneled under the skin. And what I mean by and what they mean by tunneled, or what that means, is that usually the vein or the artery vein that they're accessing would be kind of subclavian or even internal jugular, but it's accessing that blood vessel, but before it exits out the body, out at this point, there's a tunneled area of skin or underneath that tissue there, the fatty tissue. Why do you think they want it to be tunneled, not go directly into that vein? Infection. Infection prevention, exactly. Because with those temporary internal jugular accesses, right? All bacteria has to travel is right from that insertion, right to that blood vessel. But when you have a tunnel line, you have all of this space has to travel from where it exits the body all the way up into where it meets that blood vessel. So it's a lot harder for these to get infected, and they can stay in for quite a long time. If somebody needs permanent dialysis, usually we'll have them have an arteriovenous fistula or a graft. I believe there's a picture. I didn't click on the right thing. Bum bum. Here we go. This is just a picture, very rough, of what a dialysis patient might look like. These machines are incredibly complex, but you can see where somebody has an access and there's 2 lines. You guys know that blood is not red or blue. It's just always red. My family fights me. They still tell me that blood is blue when it doesn't have oxygen in it. And then I'm just like, I think they just say it to make me go crazy, but I'm also like, please don't ever tell somebody that's what you think, because I would be so embarrassed. But this is to show you kind of where it's taking blood out, going through this machine, removing extra fluid, waste products, and then returning it back into the body. This process takes hours. Sometimes, you know, almost a whole shift with these patients, depending on how much fluid they have, all issues. You don't want to be swift with this, right? Big fluid shifts, if big electrolyte or other shifts can be harmful and hard on the body. So you don't want to take everything out right at once. You slowly move these things out. It's still way faster than our body just naturally does this a little bit at a time, right? It's still much faster than we normally would do. Here, little sweet grandma, that's a pretty old picture, but it kind of gives you an idea of kind of how it looks. I've never seen somebody in a t-shirt getting dialysis. I'm just saying, I think they uncovered her for this part, right? See how she has this blanket here? 100% after that picture was taken, covered her back up. Okay, so if they make a fistula or a graft, it's a surgical procedure, and essentially you want to get where the blood vessels, a vein and an artery, are kind of connected. A lot of blood flow happening right there, and that's what they use to access for the dialysis. It doesn't take, they're not able to be used right at first. They have to be matured, right? It's when you first attach blood vessels together, or if they're putting in something to kind of attach those vessels, it needs time to heal and grow. They also usually will give patients little squeezy balls and things to like squeeze and get that blood flowing and help it to mature, is what they call that. They usually will start kind of lower in the arm, and then if those have issues, sometimes they'll move higher to form new ones. So sometimes you might see a patient that has these like big, anybody seen like a dialysis, like a fistula or something where it looks like big ropey on their skin almost? Sometimes there can be old ones that failed, they weren't working very well, and so then they'll have newer ones that are going up. When they have them, we want to educate patients on these. We want to make sure they know what to look for. If they've had them, we want to make sure, first of all, they retire that good blood flow. So we want to make sure they're not doing anything with that whole arm that would restrict blood flow. What would be things that might restrict blood flow to that?
Lying on the side.
Lying on that side, we don't want them to have blood pressure, right? Usually we give them little bracelets or things that say don't do needle sticks or anything like that. What about tight clothing? Yeah, or carrying things. Like grandma's got her purse, she always carries it on this arm like that. You might have to, you want to carry it on this other arm, because you don't want it to pull or restrict on that access. So verify the thrill and the Brewy patency. So the thrill is what you are going to feel. When you push on these accesses, you should feel this like turbulent blood flow. It's like, if that was a feeling, that's what you would feel essentially. But we also want to listen and auscultate for the Brewy. The Brewy is what you hear. You guys remember way back from your head to toe assessments, and you would listen a lot of times to hear if they had a Brewy. What does a Brewy tell you?
High blood pressure.
A lot of blood flow, right? If we're listening here in our neck, that tells us there might be some restricted blood flow, that we're getting like a lot of turbulence through there. Not a good thing. But in our access for dialysis, we want to hear that. So we want to hear the Brewy. And like you said, no blood pressure, lab draws. Want to make sure the patient knows these things so they can be a self-advocate. Oh, here we go. So here it shows the fistula. And so that's where they take your body's own vessels, artery and vein, and kind of put them together. So they're sharing blood flow. A graft. So that's, I always remember graft as being like something that's not native, right? If you graft something in, like on trees or plants, you can graft something maybe, I don't know, I always think of like the apple trees, they graft other apple trees in to make new apples. Maybe it's because we're in Washington. Yes, that's probably a better one for medical terms, right? You can have tissue, and graft that onto somebody else. So graft is like foreign usually. So it's a foreign body or a piece that they use, and they attach it to the blood vessels there. And that's what gives you that shared blood flow that they'll access. Okay, quick check. Which one do you feel for? Do you feel for the Brewy or the thrill? Okay, we have most everybody, and the answer was thrill. I think about that as like I feel a thrill or something, like I'm excited, like I feel that. And then the Brewy, I just always remember like listening for like the Brewies, and so that helps me to remember. So peritoneal dialysis, that's another type of dialysis. So for patients, they're not always candidates for this because this takes a lot of home management and self-care. But if your patient is with it mentally, can do a lot physically, or has somebody that can, they might be a candidate for this. It's a little bit less harsh on the body. One thing we didn't talk about with dialysis, what are normal dialysis schedules like for patients? Do you guys know? It's usually 3 times a week. You guys know what they usually fall on? Yep, it's usually Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So if you have a dialysis patient, you're going to say, oh, what's their schedule? And when you're in nursing and you're getting reported, people are going to know, oh, that means, are they Monday, Wednesday, Friday, or are they a Tuesday, Thursday, Saturday patient? That's the typical part. With peritoneal dialysis, it's patients that do this every day. And so they're slowly, instead of just 3 times a week, getting to get rid of the extra fluid, extra waste products, they're getting to do this every day. Now there's a couple different ways you could do this. Sometimes they just do it kind of all during the nighttime. They have machines that kind of run this through the night. When I was a baby nurse, I used to do this on my medical floor. I would do the peritoneal dialysis for these patients, and I didn't know what I was doing at all. When I think back to it now, I'm like, how did I not kill all of these patients? But we would do this. It was really interesting. So the peritoneal membrane, it's like the peritoneal area or the space, it's like a potential space. Normally, we have the inside of our abdominal wall, and it covers all of our intestines and everything. What they do is they put a catheter into this potential space, and there you go, you can kind of see where this catheter goes in, and then you flood it with this fluid. Now, based on what the patient needs, it'll have different concentrations of fluid. The person needs a lot more fluid pulled out. Do you think that it would be more hypertonic or hypotonic?
Hyper, if they need.
It would be hypertonic. We want it more concentrated that goes in, because the more concentrated it is, the more it will pull out. That makes sense? And so there is fluid that you, actually, what usually it looks like, it's a three-way catheter, because when you have it like this, first, the patient, you empty the patient. You have to have them sitting there or laying there, and there's a bag, there's a catheter, and you hook it up and you empty them out. When it's getting close to being empty, or when you first start filling, a lot of times they'll complain of a little bit of pain because that space is now starting to rub together a little bit. When you're emptying out, you're looking for things. You're looking to see what color is it? Is there any cloudiness, any infection type looking things? You might be a little bit of bloody tinge fluid on there, especially if it's new to them. Their peritoneal cavity might be a little bit inflamed and kind of getting used to it. So you might see some blood tinged. Sometimes there's little fibrinous areas to it, and you always want to measure it. Because once you empty it out, you clamp off that one, and then you fill in the fluid into that cavity. So you always, when you measure it, usually would be pretty big bags. I'm trying to remember how many liters. Let's say it was 3 liters that they infuse in. How much fluid should be coming out, more or less? It should be more, because we're trying to pull out extra fluid. Remember, they're chronic kidney disease. They're not able to excrete fluid like they normally would. So that hypertonic fluid is going to pull extra fluid into that peritoneal cavity and be able to then re-drain it out. So we always measure it. And maybe what had gone in earlier was 3 liters. Maybe now it's 3,600 mils, right? They were able to pull off 600 mils of fluid through that. So it's kind of complicated. As baby nurses, we will not start out doing this. Thank goodness. I was terrified. And a lot of times you see people doing this at home. But you can see how we want to make sure we give good education. Because what are these patients big risk for? Infection, right? Because not only do they have access to this peritoneal cavity, but they're actively accessing it, changing out things, very possible to get infection, or it's called peritonitis. Peritonitis is the infection of the abdominal cavity. When I was working as baby nurse, if we started to have, and a lot of times it's presented with pain, maybe a little bit of like cloudy, usually not pussy drainage, but it could be. They would have us put, before we filled in the fluid, we would put antibiotics into that fluid bag. And that way the antibiotics were part of that fluid that would be absorbed directly into the peritoneal area. So essentially it was like a topical treatment. Topical, we think outside, right? But it was topical to the inside of that peritoneal area. It's super interesting. I'm glad I didn't know what I know now. Moving on, we're just going to talk very briefly about kidney transplants, because for a lot of these patients, like we talked about polycystic kidney disease and other things, where there are genetic causes that cause people's kidneys to fail. We have to have our kidneys for life, right? We have to, and dialysis is not a very fun way of living. And we have the amazing way of transplanting one organ into another person. There's a lot that goes into that, right? There's a lot as far as like being on a transplant list, moving through that, making sure, compatibility is an issue. Most people have to be on lifelong anti-rejection drugs afterwards. Anti-rejection drugs, just so you know, or so make sure we're all on the same page, what system do those affect? The immune system, right? Because there's essentially a foreign body. They've done all this checking, kind of like with blood transfusions, all this checking to make sure it's compatible, but it's still not your body's own organ. So we suppress the immune system just a little bit to help it not reject that organ. So it's pretty amazing. Well, my mom, I'll briefly, she had a liver transplant 30 years ago, which is incredible. And so I am a big proponent of transplantation. One of the not nice things about kidneys, but because most of us have two of them, there can be cadaver transplants, which means somebody who passes away, they can donate their organs to other people, or you can have living donor transplants. So usually they look at if you need a kidney, they look at your loved ones. And maybe I shouldn't say loved ones. They look at family. Who knows if you love or hate your family? But those are the people that are most closely related to you as far as DNA, right? And so you have decreased likelihood of, or I guess you have increased likelihood of matching with them, that their kidney would work for you. Not always, sometimes it can be strangers. The department that I worked in that had all the kidney failure dialysis patients also did like the recovery of the transplant patients as well. And so sometimes we would see them with loved ones that were there, and it was very, very sweet because they would almost always put them in the same room. And you would have the patient who's receiving the transplant and then the patient who is going to be donating their kidney. And they would be in a double room together, and they would both go off to surgery together, right? Because you need to get that person who's going to receive the transplant ready and get them prepared for that surgery. Because as soon as that organ is harvested from the living person, they just get put over into this other one. So it's a really beautiful thing. What is FAD? So let me tell you. Living or cadaveric anti-rejection drugs for life. If you're on medication for anti-rejection, it's gonna kind of lower your immune system. What does it make you more likely to have? Yeah, it makes you more likely or more at risk for infection. We really want to look at these patients and see how we can protect them and keep them safe, because even though their immune systems might be working really good, we're keeping them a little bit suppressed because we want to protect the organ. Okay, here's kind of a picture. Oftentimes, if you have a transplant, they won't remove your previous kidneys. They just put in the new kidney, and it's usually a little bit lower, and just on one side. So this is a picture of what it could look like. So if you ever have a patient that has a transplant, look at their CT or their X-ray abdomen images. I bet it looks pretty different than the average person.
So they initially don't remove that. It makes that odd.
They usually don't, but
I thought it was like really interesting. They just shrivel up and your body doesn't even like cannibalize them, like nothing. They just hang out like little shrivels.
yeah, this picture kind of shows how they're just kind of,
Cause even removing them, I think raises the risk of infection.
right, they're not causing harm by leaving them there. And you open the patient to more complications by going in and removing them.
But that was different. It was like cancer.
Exactly, yeah.
They're just little shriveled grapes. Yes.
Non-functional.
They don't do anything.
Only one.
The patient like doesn't want to go through more dangerous surgery. So I wanted people stop touching them.
Okay, we're gonna end the Menti because we have so many fun things. Oh, we're not gonna be able to do it all. Okay, I'll let you guys choose. I really want to do the NGN case study, so we're gonna do that. Do you guys want to do the other case study or name that patient?
Name that patient.
Name that patient? All right, stick with what you know. All right, let's do, let's do name that patient. The case study I gave you guys, right? You guys all have that case study. Use that as a study guide this week when you go through and you look at, when you look at things, I'll publish the answers so you can see those as well. Okay, so name that patient. You guys are all in your groups? Ish. So just like before, go ahead and give me a patient scenario. Be creative. For a patient with this. Oh.